So this next group of drugs are what are classified as pro-kinetic agents, and I thought this was a timely photo. When I first wrote this lecture, we were potty training my kids, and I remember reading this story called "Every Princess Poops" to my daughter to urge her to sit on the toilet, and then she wouldn't sit on the toilet until she had the newspaper, apparently like her old man. So it's funny how kids grow up and see what you do and then adjust to that. So for drugs, so prokinetic agents are basically used for people that can't go. Or they have a hard time going. And so the prototype here is metoclopramide under the brand name Reglan. If you have any clinical experience at all, you've probably heard of Reglan because it has a lot of different clinical indications outside of GERD, but also diabetic gastroparesis, prevention of nausea and vomiting in cancer patients, patients who are undergoing radiation or chemotherapy, patients coming out of anesthesia, several different clinical indications, many of which are not listed here, just this is a few. So mechanistically, we're not going to dwell too much on this because we haven't gone into the CNS component yet, but essentially metoclopramide is a cholinergic agent, so this is a acetylcholine agonist type drug, but it's also a dopamine subtype 2 receptor antagonist. And so we'll spend a lot more time on that, but that's pretty much all you need to know about metoclopramide. Mechanistically, we're going to be through its cholinergic actions. Whenever you see mimetic, that means agonist. So cholinergic means acetylcholine agonist. Promotion of release of acetylcholine in a specific location within the CNS called the myenteric neurons. And so basically, this is the stepwise approach as to how this drug works. And you don't really have to worry about the mechanisms because we don't really have the basis of the biology behind us yet. But so what you see is a relaxation of the pyloric sphincter. As well as an increase in the contraction of the stomach. Okay, and so this is a really helpful drug for these patients that are listed here. The side effects are basically the side effects to having excess amounts of dopamine. And so all of this side effects that are listed here basically describe what happens when there is too much dopamine on board in a specific location within the CNS and the peripheral compartment. So, but the biology for a lot of this is not going to make sense, but we're just going to go over it briefly from an organ-based perspective. Another drug that's really useful for being a prokinetic agent, and so pro-movement or propelling the GI system forward, is Cisapride. This is again going to go after acetylcholine as well as this is serotonin. 5-HT is serotonin. We'll see enhanced peristalsis. We'll see a dramatic effect on the colon, and we don't see this drug quite used as often because we actually saw patients who were treated with Cisapride develop torsade de pointes, which you'll remember from the anti-arrhythmia or from the arrhythmia cases that we had just done last year. Side effects are listed here. Okay, so opposite of prokinetic agents, so patients that need a little bit of chemical assistance to move things forward. Laxatives are kind of within that realm. So these are for patients that simply are just constipated. So I do have a funny story. I worked in retail pharmacy for about 4 to 5 years when I was in college in the first year of grad school, and we had a patient come in who was a regular patient, and he was constipated, and he was taking so many medications. All of the drugs that we're about to talk about had actually either not worked or were contraindicated because they interacted with other medicines he was on. He was quite a sick elderly man. He also had a really good sense of humor, and so he came in complaining about being constipated, and basically the pharmacist told him that all cues had been exhausted. Let's page the doctor and see what the doctor recommends. And so it was a Friday afternoon. The doctor was a little bit late calling back, and the man was getting upset. And so I was a technician at the time. I think I was maybe not even 20 years old, 19, yeah, about 20 years old. And so I called him back and I said, listen, buddy, I said, go to White Castle's and get a sack of 10 and basically sit back and wait. And he called me that night, and and said, it worked. We did not use any drugs that we were going to talk about in this section. A stack of 10 White Castle basically took care of his constipation problem. You could have easily substituted this White Castle for Taco Bell or any fast food, basically. So I thought that was pretty funny. It worked, though. So what do we need laxatives for? So, there's short-term use for them, and then there's long-term use. Some people, you may be one of them, are chronically constipated. Others maybe only constipated during stressful times or when they're sick. So there's a few different approaches. We can increase the fiber in the diet, which is actually beneficial anyway. We can increase fluid intake, and we can exercise. All of those things will not only alleviate constipation, but will also increase quality of life. We can also look at osmotic agents, and so these are typically drugs that will bring fluid into the GI tract to basically make the poop more slippery, so it slides out a little bit easier. In order for these to work, the patient obviously has to be properly hydrated. Those drugs include saline, PEG, which is like a pegylated form. It's not antifreeze. Everybody thinks it's antifreeze, but it's similar to antifreeze, right? And then sorbitol, which is basically a undigestible sugar. There are surfactants and lubricants. Docusate, lactulose, mineral oil can actually be ingested and will actually lubricate the GI content so that releasing them is a little bit easier on the patient. And then, of course, there are bulk forming agents, and Metamucil is the prototype here. Metamucil is really the hulls of a specific seed called psyllium. It's really safe, really effective, but patients do complain of being, a bloated type feeling as well as flatulence. And this is what psyllium looks like if you've never opened up a bottle of Metamucil and had a look. All right, and so groups of patients that require laxatives are, very, very broad categories. Kind of along that same token are patients that take chronic opioids, codeine in particular, for pain management. And so the most common side effect to any type of opioid, and we'll talk about morphine and codeine and all those other drugs in the CNS portion, but the main side effect is constipation. All right, and so patients that had chronic pain and who were taking, high dose morphine, high dose opioids, often relied on many of these drugs continuously because they had complained of, potent constipation and persistent GI bloating and GI upset. And so what's interesting is that over the years, now there are new drugs that are coming out specifically for the treatment of opioid-induced constipation, and now it's actually a thing. There's commercials out there for what they call OIC, opioid-induced constipation. Those two drugs are listed here, methyl naltrexone and movantinib, or naloxone. And these are peripherally acting selective competitive antagonists, and this is a new drug class called PAMORAs, at the mu-opioid receptor. So they don't cross the blood-brain barrier, but they do affect, and then they do not affect pain management. And so typically all these drugs do is they basically go through the GI system and basically antagonize or compete with codeine at this mu-opioid receptor within the GI tract. So it's interesting that a drug class actually gave birth to another drug class just because of the side effects. So don't worry too much about the mechanism here. What I summarized was basically enough for what you need to know. We'll go through more of these mu receptor signaling cascades in the CNS portion of the curriculum. So let's end here, and we will resume with antidiarrheal agents next.